Friends, warm welcome to all of you. It is 8:30 and 8 o'clock, and then now we warmly welcome today's faculty, Professor Ratna ma'am, who is right now head of the department at the SGT Medical College, Gurgaon. And we have our own Professor Rajiv Sahai sir, who's been with us for so many years. And we have Professor Srinivas Rao Lukala sir. He is a professor and head of the department at Government Medical College, Rajahmundry. We have Dr. Tarun Mittal, who is expected to join shortly. And we have very eminent students today, kindly contributed by Professor Dorai. He is Dr. Sairaj, and then the other candidate is kindly contributed by Dr. Hitesh Andaria from Narendra Modi Medical College. So today's case discussion will be on oral cancer and inguinal hernia. Very common case kept for the exams, but then many times people get challenged because of the ease of it and tough nature. Because the questions asked are so common, but then you are expected to answer to the point, and many times this becomes a challenge during the exams. So, friends, without much ado, I hand over the day's proceeding to both the senior faculties here. And I call upon Dr. Advait to start his presentation. Please introduce your unit chief and head of the department and start your presentation, Dr. Advait. So good luck to you. Dr. Sairaj had some issues with this connectivity that I will sort out offline. So faculty, please take over. Thank you very much. And on behalf of all the faculty here, I wish you advanced Independence Day wishes. And I'm sure this inspires us to do more for India and then let us make India a great country. Thank you very much. Advait, you can start your presentation. Faculty, please take over. Make it full screen, Advait.
Yes.
Yeah, perfect. Good to go. Take care. Good. Best wishes,
Good
Advait.
evening, everyone. Um, I am Dr. Advait Kelkar, second year general surgery resident at Narendra Modi Medical College, Ahmedabad. My PG teacher is Dr. Hitesh Andharia, sir. I'll be presenting a case on inguinal hernia. History. A 64-year-old male patient from Hatkeshwar, Ahmedabad, a laborer, presented to surgery OPD with chief complaint of swelling in right side groin for 3 years and pain over the swelling since 3 days. History of presenting illness. The patient was relatively asymptomatic 3 years ago when he accidentally noticed a swelling on his right groin region. Initially, the swelling would appear on standing and straining during work and disappear on laying down, gradually progressing from a small swelling in the right groin region to current size reaching up to the base of scrotum. Since last 3 days, the swelling has not reduced on laying down or on manual pressure by the patient. Swelling is associated with pain, which is intermittent, dragging in nature, and increased in evening on straining, standing, walking, and decreases on lying down. There is no history of chronic cough, no history of constipation, no history of hesitancy, urgency, narrowing of string, or dribbling of urine, or increased urination frequency at night. There is no history of abdominal pain, abdominal distension, nausea, or vomiting. Past history. There is no history of hypertension, diabetes mellitus, tuberculosis, and no history of any previous surgeries. The patient personal history consumes mixed diet with normal appetite. Bowel bladder habits are normal. Sleep patterns are unaltered. The patient is a chronic BD smoker, smoking 7 to 8 BDs per day for last 25 years. And family history, there is no significant family history. Summary. A 64-year-old male patient presented with chief complaint of a reducible swelling over right side groin region since 3 years, which gradually increased in size to reach the base of scrotum and is associated with dragging pain and has become irreducible since last 3 days. Uh, will I
Go to
continue?
your first slide, please.
Yes.
Hitesh, Advait.
Yes.
So instead of using the word right side groin, right groin, better you can use it.
So what is your
Okay.
interpretation from this? There was a swelling that you already had and now it's irreducible for last 3 days.
Yes, ma'am.
What do you interpret from this?
Ma'am, the
Just
patient
let
is
me
having
mention some things.
a right-sided groin hernia, most probably irreducible inguinal hernia.
So do you think he has an acute problem or do you think it's a chronic problem with an irreducible hernia?
Ma'am, it is a acute acute on chronic problem. He had the swelling since 3 years, so but the swelling was reducible.
So now that it
Up
has
and
become irreducible, what
yes, ma'am, it
history
became
have you
irreducible
taken
since
with
3.
respect to irreducibility to say whether we are dealing with an acute scrotum or not?
Sorry, ma'am, I couldn't hear you.
Yeah,
See,
what madam is asking is the same question I want to ask. Say, so what additional features you want to know why it has gone into an acute emergency or not?
Okay.
So depending on
Then
the history.
we would look for any abdominal symptoms, obstructive symptoms like vomiting, constipation, obstipation, and
no, don't beat
abdominal
around the
pain.
bush. No, don't beat around the bush. Now that he has an irreducible swelling, do you think an irreducible swelling can be a chronic irreducible swelling also? Or must it always be an acute problem, which
It can be
needs
a
some
chronic.
intervention? Yeah.
It can be a chronic swelling.
So now, is this a chronic problem? Is this an acute problem needing an immediate intervention based on the history?
It is an acute problem, ma'am, because the swelling became irreducible 3 days since it is irreducible since
Yes.
3 days, and it was the onset is since 3 years.
What are those features in the history that you were talking about that would tell you that this patient may need some intervention as an urgent requirement?
Sudden onset of pain,
Yes.
and abdominal pain, vomiting, signs of obstruction,
Okay. Yes.
then
Anything more?
tenderness over the
Anything more?
swelling, redness.
To produce redness, what there should be in the symptomatology?
Sorry, sir, I couldn't hear you.
To produce redness, what should be there in symptomatology? So you said irreducible, there is redness, there is tenderness. You'll be looking for that at a later time. But before that, what symptom suggests you that it is an acute onset and it is an emergency?
Sudden
You would like to go for any constitutional symptoms like fever?
yes, sir. Fever, sudden rise in pain.
Yeah.
Now, from the history, have you
Hi, good evening.
as to what is the cause of this sudden development of increase in the size of swelling? You said there is no history of cough, no constipation, and you listed a set of symptoms of urinary complaints. What do you think could be the possible reason for sudden increase in size of this swelling?
Ma'am, the patient is a laborer, so due to straining while working, it may have.
So that is what you should have specifically asked. Was there a strenuous work that he did before he developed this swelling? Or you should have asked history of sudden loss of weight.
Then also
Right? Did you give us that history?
no.
Hello. Yeah. So these are two things that you must keep in mind as to what is the precipitating factor for development. Why did you take this specific history of this list of urinary complaints?
To rule out any prosthetic enlargement or
Yes, there are
strictures.
symptoms of irritation and symptoms of obstruction. So you need to phrase your answers correctly. So you should say that you were looking for any features of obstructive uropathy, right? Yeah. So what are those features? What happens to the stream of urine on straining if there is benign hypertrophy of prostate?
There will be weakening of stream. There will be dribbling of urine.
No, no. On straining, will the stream improve or will it weaken further?
It would weaken
In a
further.
patient of PHP, if the patient will strain, what will happen to the stream of urine? So in a patient of PHP, it will decrease further on straining.
It will further decrease.
Okay. While in a patient of urethral stricture, the stream will improve on straining. Right?
Yes.
So
Why? What is the cause? What is the reason for that? What madam has said. What is the reason for that? Why in benign prostatic hypertrophy, the stream will be further narrowed if the patient strains?
Because on straining, the prostate would press upon the bladder neck. So on further straining, the obstruction would increase. But in a stricture, the straining will increase the pressure proximal to the stricture, so of urine. So that would increase the strain.
Most commonly, what lobe of prostate would be enlarged in benign prostatic hypertrophy? You know that that answer will be there.
Median lobes.
So the median lobe. So on straining, the median lobe further goes into the prostatic urethra and obstructs further. That is the answer what madam wants. Okay. So go to next slide, please.
Please go on to the next slide. Is there anything in the history that tells you that this patient is predisposed to development of hernia? Anything positive in the history?
Ma'am, he's a chronic BD smoker. So
yeah. So what does that do to make him prone to?
It would cause weakening of abdominal muscles due to impaired formation of collagen.
Which collagen is good collagen and which collagen is bad collagen? What are the types of collagen that you know of?
There are type 1 to 7, and nicotine would affect the synthesis
Be
of.
loud and clear. Basically, we talk about type
Collagen 1 and 3 are the.
Yeah. Right. So, what is the basic element in collagen which gets impaired? So it is hydroxyproline, which is an element which gets impaired, right?
Yes.
Due to maybe smoking or due to taking tobacco in any form. I think can we proceed to. So what you need to know is the acute symptoms that you need to ask for is sudden history of irreducibility with pain, with the swelling becoming tense and red, right? And then it may be associated with features of obstruction or in later stages, features suggestive of peritonitis. So, but the swelling becoming tense and red all of a sudden is an important feature which points towards strangulation. Can we move to examination, sir?
Yeah,
anything else?
Next slide. Next slide. Next.
You said no
Okay.
significant family history. What
Yeah.
family history did you ask him?
Ma'am, any family history of inherited disorders for collagen disorders, Marfan's, Ehlers loss?
Yeah. So be specific about that, right? Don't write no significant family history. Write
So
about specific.
among the different types of hernia, which type of hernia can run in families?
Direct hernia?
No, think and reverse. It's indirect hernia. Indirect hernia is more likely, whereas direct hernia is more because of his habits is more likely to develop. You see, most of the adults, most of the old people, they develop because they strain at urine. Most commonly, it is a direct hernia, not the
Yes.
direct in an indirect hernia. Okay. Yeah. Next. Yeah. Go to general examination. Yes.
One cause of dragging pain. What is the cause of dragging pain?
It may be due to the stretching of the sac, ma'am, due to the parietal peritoneum,
Stretching of the sac or anything else.
or the content as well, the omentum or mesentery can cause pain.
How does the momentum or mesentery? It is more likely say your answer should be the drag on mesentery produces a dragging pain. So when the contents go into the sac, they drag on the peritoneum, and the mesentery or the momental attachment, and that causes dragging pain. Okay.
Yes.
Yes.
Proceed to examination.
General examination. I've examined the patient in a well-lit room with adequate exposure. The patient is conscious, cooperative, and oriented to time-place person. And the patient is afebrile, pulse rate being 82 beats per minute and regular. BP 128 by 84 mmHg. SpO2 98% on room air. No pallor, no icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Local examination. The patient is examined in standing and supine position. On inspection, approximately 20 by 7 centimeter sized pyriform shaped smooth single swelling was seen in the right inguinal region, reaching up to the base of scrotum. The skin over the swelling is stretched, and there is no discoloration or redness present. Cuff impulse is absent on inspection. No visible peristalsis is seen over the swelling, and the penis is deviated to the left side. On palpation, the temperature of the swelling is normal. There is no tenderness present. Approximately 20 by 8 centimeter pyriform swelling with smooth surface and ill-defined margins is present on the right side, extending from right inguinal region to the base of scrotum. The swelling was noted to be of soft and elastic consistency. Bilaterally, testes were palpable separately, and getting above the swelling is not possible. The swelling is irreducible on laying down, and cuff impulse was absent on palpation. Percussion, there is a resonant note present on percussion, and vowel sounds are heard over the swelling in auscultation. External genitalia is normal. Per abdomen is soft and non-tender and non-distended. Normal vowel sounds are heard, and rest of the hernial sites are normal. Abdominal muscle tone is decreased. Malgignes bulges are present. On per rectal examination, there is no external visible skin tag, or anal tone is normal. Stool staining is present, and no prostatomegaly is present. Respiratory system, bilateral air entry is present and equal. Cardiovascular system is normal, heart sounds are heard, and central nervous system, conscious and oriented patient. My provisional diagnosis is a right-sided, irreducible, complete, complicated, indirect inguinoscrotal hernia with enterocele.
Now, how did you know that it is an enterocele?
Sir, on palpation, there is the consistency is uh, elastic, and
Yes.
It's a definite thing that you can elicit in the history also, and even on examination, which will tell you that it is an enterocele, other than elastic consistency. Elastic consistency is a very subjective thing. But there'll be something very definitive which will tell you, which you can elicit in history also, and even elicit on examination.
On reducing the swelling, there would be gurgling sound present.
Yeah, so even the patient could have given you the history
Patient
that
would give
earlier
the
it used to reduce with a gurgle, and
Yes.
on examination, if you can palpate gurgling while you are examining or see visible peristalsis, that will tell you that there is, that will be a definitive evidence of it being an entero. What is the importance of knowing whether it is an enterocele or it is not an enterocele?
And the involvement of bowel would
It is a definitive indication of surgery, even in a
Yeah.
geriatric age group patient, you know. In very old patients also, if you find there is an enterocele, you would want to operate, right?
Yes.
So when
Also,
we, if we go back to
also the way in the approach for approach for the surgery also differs. If it is pure romentocele, you can always resect it laparoscopically also. Whereas enterocele, of course, some experienced surgeons they do it, but it is preferable to do it in open method.
Yes.
so
Dr.
if we go
Advait,
back to
Dr. Hi, good evening.
patient,
I just wanted to
Yes.
ask you, why did you do a percussion on this patient? Why? What information did you get by percussing? Do you percuss a hernia in your OPD?
and where did you percuss and in which position? You don't need to percuss. No? It's a mobile structure.
On
So
percussion,
Yeah,
it's not a
Advait.
good idea to percuss it. It's mentioned in some books, you are right. It is not a Dr. Sahai is right when he says that. You should not percuss on this.
Right.
So these
If you
things,
want to know it's an enterocele, if you
sir,
want to know it's an
can
enterocele, just auscultate.
can I add something, sir?
Yeah, sir, please.
Sir,
Please.
can I add something, sir? Sir,
Yeah.
because I don't, I mean, because some examiners they insist on percussion also. So to know that whether it is an enterocele or not. So as a part of say, if somebody asks, normally Advait, you don't need to percuss. But if
Yes.
somebody asks, "So did you do percussion?" Then you'd have to catch that point and you have to tell that, yes, sir, I percussed and it is resonant. So that is a safe way of getting out. Okay.
Yes.
Yes, sir. Sir,
So-
you're telling something, sir. Rajiv, sir.
No, that's fine. Usually, because it's such a mobile structure, you got to hold it and then percuss it, right? It's kind of very clumsy, and it gives us no information. So do away with it. If someone asks you, like sir said, fine, do it, but
Yes.
not required.
When you describe examination, instead of calling it local examination, please say that you did regional examination of groin and abdomen,
Groin.
right? And what did you tell us about the other hernial orifices? Do your
Sorry, ma'am.
slides speak about
Which
other hernial orifices? Can you go back to the slide that tells us about other hernial orifices?
The rest of the
Have you
hernias.
made a mention of other hernial orifices other than the groin? So in
which
any
other
patient,
hernial orifices?
please do talk about other hernial orifices also, whether the umbilical area is normal or not, epigastric area. Do evaluate for femoral hernia also, which you would have done.
Yes, ma'am.
Yeah.
What are
Another
the
thing
other
important,
things?
which I think is very important, you have not examined the penis and the testes. You've not told me anything about the external meatus, urethral meatus, whether he's got phimosis or not, right? And whether the testes
Single sentence
are
note of the
palpable
fact.
separately, right? So all this has
Yes.
to come up here.
See, just saying that external genitalia is normal will not suffice. You have to talk about these features that Dr. Sai is talking about. And you must palpate for the urethra for urethral stricture also. Where do you palpate the urethra for urethral stricture?
We would look for the root of scrotum, root of penis
You palpate on
for
the
the bulbar
ventral
urethra,
surface.
any stricture at the bulbar urethra.
You palpate on the ventral surface of the
Ventral.
penis.
Yes.
Right? So you said that you did a DRE. What all did you look for in DRE? You said no prostatomegaly.
Yes.
He's a 64 years gentleman. What is it that you specifically looked for? And what is the first sign of prostatomegaly on digital rectal examination?
First sign would be, ma'am, that we can't we can reach the upper
The
border,
first sign
but
is
the
deepening of the lateral
deepening of the
grooves, right?
median sulcus.
What about the median sulcus in this case? And what is the importance?
If the median sulcus is easily palpable and upper border is palpable, it would be
No.
the
If the
early
median
stage.
sulcus is not palpable, what does it suggest?
Ma'am, grade 3 or 4
Not
prostatomegaly.
at all. If median sulcus is not palpable, you have to have a high index of suspicion of malignancy.
Yes.
Right? So you have to make a conscious effort to look for these things. What else did you look for in prostate? You need to look for mobility of mucosa,
nodularity.
mobility of prostate, right? Besides the size that you can grade the prostate on DRE. So if you talk about DRE, you have to know what you are looking for. Okay, besides consistency, nodularity, and all that. Okay, so why did you look only for Malgaigney's bulges? What are the other signs of weakness of abdominal wall muscles?
So, all the more nowadays, everybody is giving so much of importance to that structure.
So you need to look for divarification of recti also.
Yes.
Divarication of
Okay.
recti. So nowadays, the divarication of recti is given so much of importance in any hernia repair, both ventral and otherwise. So you have to compulsorily repair the linea alba whenever you are attempting any hernia repair.
What is the difference
Not
in
of course.
divarification that you get in ladies as compared to what you get in men?
Sorry, ma'am, I couldn't hear you.
What is the difference in divarification of recti that you get in ladies as compared to what you get in men? So in men, divarification is usually in the supraumbilical area, while in women, it's in the hypogastric area.
Gastric.
Okay, how did you look for Malgaigney's bulges?
There are two tests, ma'am, leg raising test or neck flexion
So
of
leg raising
neck
test
against.
the recti. No? With leg raising, you will test the recti. That will tell you about divarification of recti. So specifically, if you need to look for Malgaigney's bulges, what will you do?
And flexion of the neck against.
No, so Malgaigney's bulges are due to weakening of the oblique and the transverse muscles of the abdomen. So you look
Yes.
for that by doing Valsalva's maneuver. How do you do Valsalva's maneuver?
We ask the patient to exhale.
See, don't take too much time in
Against the closed.
answering these questions, no? You should be ready with them. So, on blocking the
Expiration.
nostrils and
Blocking the
blowing
nose.
against the closed mouth, right? When the patient strains, the oblique muscles of the abdomen become taut. So that will tell you whether there are Malgaigney's bulges or not. And also in standing position, you'll be able to see the bulge in the groin area. What test did you do to say that it was an inguinal hernia and not a femoral hernia? Dr. Advait?
How? Hello?
Yes.
Yeah.
Hello.
What test did
Yeah.
you do to tell us whether this
How do you
hernia
say it's
was
not a femoral hernia?
In a femoral hernia, the swelling couldn't reach the base of scrotum, ma'am.
Hmm.
Hello.
Yes, yes.
Yes.
So, is it above the inguinal ligament or below the inguinal ligament?
It is above the inguinal ligament, sir. Above and
Femoral
what
hernia.
is the
Femoral hernia.
relationship of
yeah,
the
femoral is
hernia?
below and lateral.
Below
What
and
is
lateral. So, inguinal will be above and medial or lateral, whatever it is.
You need to
Okay.
talk about the relationship of hernia to the pubic tubercle, right?
Yes.
What are those conditions in which the femoral hernia may be present above the inguinal ligament? So, in a large femoral
Large
hernia,
defect, ma'am.
it takes the shape of a
It
blowhorn
would be
or a.
right.
So then the fundus may reach above the level of inguinal ligament, but the base will
Yes.
always be below and lateral to the pubic tubercle. So it is a relationship to pubic tubercle. Any test that you are aware of that tells you whether it is direct, indirect, or femoral?
Siemens three-finger test, ma'am.
What is the scientific basis that tells you that you may not be able to elicit things clearly with Siemens test? Because the brain can interpret two things at a time. For it to interpret three things at a time can be difficult, right? So you need to test two openings at a time. So this is
Moreover, say in case of an indirect hernia, you may be able to palpate the impulse both at the deep ring as well as the superficial ring, because it enters through the deep ring and exits through the superficial. This is one I'll say about Siemens technique. Got it, Advait?
Yes.
Yes, sir.
So
Yes.
what about
Yeah.
the size of the deep ring and the superficial ring?
Size.
So if we told you to classify this hernia based on the European hernia system, how would you classify it?
Ma'am, would be am I not able to recollect?
Here, then you need to know that you need to talk
Yes.
about whether you're dealing with medial or a lateral hernia, and then what about the size based on either
So,
1.5 centimeters or finger breadths?
which
Yes.
is a primary one or is it a recurrent one? P and R, it will be there. Lateral or medial,
Yes, sir.
and the size of the cell, size of the deep ring. So that's why you need to know about the width of the deep ring. Yes.
Sorry, sir.
Yeah. So let's go to the next slide and see what your diagnosis is. So why did you say it was an indirect hernia?
Indirect.
Why
Because,
did you
ma'am,
say it was
the
an
swelling.
indirect hernia?
Because the swelling in an indirect hernia would reach up to the base of scrotum, and
No, see, be very clear about what you're speaking. No, how can you say what you're seeing is an indirect hernia? It's an irreducible swelling. Most likely it should be indirect, but whether it is direct or indirect, so you will be able to say only after you've been able to reduce it and you do a deep ring occlusion test.
All your tests will be cannot be performed unless the swelling is reducible.
It is reduced.
Be it a Siemens technique, be it a ring occlusion test, whatever it is.
So
Only in the reducible swellings.
did you try to reduce the swelling to see whether it was reducible or not? Did you find
No, ma'am.
out from the
I asked
patient?
the patient to reduce the swelling, but
So what is it that you can do to check whether the swelling is reducible or not? If it is not, sorry, if it is not an acutely irreducible swelling, what
in
test, what can you do?
taxes
Tell me
can be
some
done.
maneuver that you can do to facilitate reduction of the
We can
contents.
do taxes, ma'am, where we would flex the hip, adduct, and internally rotate the hip.
Yeah.
So
So what does
did
that
you
do?
ask the patient to did you ask the patient to reduce himself?
Yes, yes, sir.
That's the best way. So because
Yeah.
he's habituated to getting it reduced, so that's the best way of doing it. Then if he cannot do it, so guide him
Then,
the same steps: flex, internally rotate, and adduct. Why do you want to do this?
it would relax the superficial inguinal ring, sir. The the true thrust of the ring would be relaxed, and the abdominal muscles would also be relaxed due because of
Why
flexion.
is taxes discouraged? Why
So
do
why?
people
What
say
are the complications of taxes?
If it is a uh, if it is a strangulated hernia or if it is a obstructed hernia, if we
need to
reduce the
know?
swelling, then it may cause reduction in mass.
Yes, en masse
What is
reduction
meant by
can happen.
reduction? What is meant by en masse reduction?
The strangulation or the obstruction has not relieved itself, and the whole sac has reduced in itself, sir.
So the
So
sac
the
with the
patient will present
whole
with
strangulation
symptoms.
together get
So the
reduced
whole
inside.
sac along with the contents has gone into some other extra peritoneal space without actually the contents getting reduced. So the strangulation can still progress.
We progress.
That is reduction en masse. Okay. Yeah. Other complication, as madam is telling, perforation.
Perforation.
If it's a bowel, it can perforate. Yes.
So how will you manage this case? Is there any other differential diagnosis you want to keep?
Yes, that is more important. So suppose the patient does not give a proper history of reducibility and the same patient presents to you. So what other possibilities would you like to entertain?
It could be a diffuse lipoma of the cord. It could be a varicocele. It could be a
Such a large lipoma of the cord.
large lipoma.
Unlikely, no?
Unlikely.
What else? More
You
important.
need to tell us that what you are dealing with is not hydrocele of the hernia sac. What are the points against that? You said it's an irreducible swelling. If I tell you that the neck of the sac is obstructed with omentum and there is fluid collection distal to it.
Yes. If it would have been a hydrocele, ma'am, the consistency of the scrotal, the swelling would be different. It would be.
You need to tell us, no, that it was a tense and elastic swelling. You did not feel it was cystic. But if it is elastic, then you also must still do a test for fluctuation and transillumination. If at all you need to keep a differential diagnosis in such a case, it could jolly well be an obstructed hernia with omentum obstructing the neck of the sac and fluid collection distal to it, or just an omentocele or omentocele with an enterocele. But when it looks as though you're very sure that it is an omentocele. I mean enterocele. Now tell me which out of these two is easier to reduce, enterocele or mentocele? And why?
It would be difficult to reduce initially, and the later part of the reduction would be easy.
Why?
Noventocele,
Why does it so happen that enterocele is difficult to reduce to begin with? So there is this rule which is also some people propose, which is called rule of triangulation, right? It is the apex of the triangle that would go in comfortably. When you press a bowel loop, then it gets distended with air. So the base of that triangle goes against the opening and it becomes difficult to reduce. While in momentum, when you press it, it will form an apex of a triangle which will go in easily. This is one explanation that is given by some, right? Otherwise, you can just say the bowel gets distended with air and hence it's difficult to reduce.
So not only that, the usually the serosal surface of the bowel, they slide on each other and they suddenly slip. That is one explanation which is also given. Okay.
okay.
So how will you manage this case? Good evening, Dr. Khanna sir. So anything to add, sir?
Please tell what are the fallacies of the deep ring occlusion test?
Deep,
Deep ring occlusion test. What are the fallacies? Sir is asked.
so in the deep ring occlusion test, we can only differentiate between direct and indirect hernia.
Oh, fallacies, fallacies. Fallacies means when can it go wrong?
Yes.
Deep ring defect required.
So what
will
happens?
happen?
Suppose if it is a very large defect, very large, the deep ring is very large, more than let us say 4 centimeters.
What if it is a recurrent hernia? Okay, so in a large defect, in a recurrent hernia, it may not hold true.
Yeah.
How will you manage this patient?
Let me ask you one question. Do you really
Yes,
want
sir.
to know in this era of laparoscopy whether it is a direct hernia or indirect hernia? If not, why it is not needed? Did you get my point?
Yes, sir. In,
Yeah.
laparoscopically, we can identify both the sacs.
So you will be covering both direct hernia and indirect hernia as well as the femoral hernia. All the orifices will be covered in laparoscopy. Without covering, you cannot do a laparoscopic hernia, whether it is a TEP or TAP. So, okay. So that is reason
Yes.
why in the modern era it has become relatively less important. But you need to know.
Swellings which has got the cuff impulse.
Yeah.
After
So,
the hernia.
how will you manage this patient?
I would like to. We would go for operative management, ma'am, where we would do open anterior approach.
No, Advait, you don't
Yes.
decide whether you're going to operate or not. You have to counsel your patient. So you counsel your patient. You can't decide whether I'm going to operate. He says, I don't want surgery, then. So you counsel
And,
the patient.
So
yes, sir.
he has come to you at 6 p.m. in the evening in emergency. Do you think he's a candidate for emergency hernia repair?
Yes, ma'am, because it can. There is a risk of it becoming a obstructed hernia or
No,
incarceration.
suppose he comes to your emergency at 6
Possibility is
p.m.
there.
with this condition.
But other
What do you
than
do?
that, you've told us
What do you do?
no sign.
No signs,
It
just
means
like this. It's come like this. What do you do?
would you
I would
need
counsel him to get that he would require an operative management. Uh,
When? When? At night? At 7
no,
p.m.?
sir, it can be a planned uh,
Yeah,
operation.
so till then, what do you do? You said it can obstruct. He can start vomiting at night. So what do you do till then?
You'd like to do any maneuver to spontaneously reduce?
Taxes, sir?
Not taxes. Spontaneously, I'm telling. Taxes means you
यार
are doing some
टैक्सेस तो
maneuver.
वो का पेशेंट करके करके हार गया.
Sorry, sir, I don't.
No, you are in casualty. The same patient has come to you at 6 p.m. So you are making ready for the surgery. Your counsel, they said that they are still talking and they want to let you know whether they want to get operated or not. In the meanwhile, what would you like to do?
Advait, you must be doing it in emergency. You must be getting this kind of hernias.
Yes, you
Do
must
you?
be doing
Yes.
no.
Yeah. So what do you do? Tell us. Simple. You will
Yes.
sedate the patient and you
Yes.
raise the foot end of the bed. Slowly by gravity, the thing will go back in.
Yes.
You get me?
Are you doing it or not?
Yes. Yes, sir.
Yeah. You keep the patient nil orally. Don't ask him to eat or drink.
Yeah.
Sedate him. Keep the bed and foot end raised. What else will you counsel him? How do
Sorry,
you
sir.
counsel this patient?
I
He
would
says, I don't want
explain
surgery.
risk of.
He says, I don't want surgery. Now, what do you do?
I would explain him the risk of obstruction and even strangulation of the bowel,
So,
which would
so the risk of not operating, what are the
not
risks of
operating.
not getting operated?
Yeah, it may there will be obstruction of bowel or strangulation, or if the any other content is involved, inflammation.
Very good. So he says, okay, I'm ready for surgery, but I want laparoscopic surgery. I've heard that this is very good. I want laparoscopic surgery. Now, what do you do?
If we have the expertise and instruments available, we can.
You are the surgeon, Advait. You are the surgeon. If you don't have, that's not question. Do you have or you don't have?
No, sir, I would explain the patient that it would be a better plan to do an open operative
Why?
management.
He says, I want lap. So why are you insisting that he should get open? Isn't lap a possibility?
So what is a must while doing a laparoscopic hernia repair?
The For a primary unilateral inguinal swelling hernia, sir, we go for the open approach first. It is preferred.
No. You didn't answer my question. So what is a must in laparoscopic hernia repair? Do you need to put a mesh or can you do without putting a mesh in laparoscopic hernia repair?
We put a mesh.
So suppose if the patient is having a strangulated hernia with all inflamed contents, can you keep the mesh?
No, sir. In case.
So that's how you need to.
Yes, sir.
That's how you need to counsel.
So, but in this patient, he says, this is the patient. He says, I want laparoscopy. He's insisting. Now, what do you do? Send him home.
No, sir, we can't send him home.
Then Are you proficient in doing laparoscopic? Advait?
No, sir.
Yeah. So then you call someone who knows. Call your senior.
Call and see. Call
Tell him
senior.
I don't do. Tell him I don't do. I will call my senior. If he's there, he will do it. Otherwise, I will do lab open. If you want lab, go to some other place, or I'll call someone else to help you. Okay. So
Yes.
what is the advantage of lab over open surgery? Or what is the advantage of open over lab?
Open surgery would be more quicker, less time consuming, and
No, that's not.
No, that
time is
depends
not a
on
factor.
learning curve.
Advait, time is not a factor in surgery ever.
In
Yes.
Unless
surgery,
you have.
ever.
Phrase your answers correctly.
okay, ma'am.
Talk about learning curve, no? Talk about a resident-friendly procedure. That's what Lichtenstein's was all about, no?
Yes.
It was found to be
Okay.
most resident.
Dr. Ratna said learning curve. I believe that Advait is the top class laparoscopic surgeon. Now, you have both open and lab. What are the pros and cons?
If the patient insists on laparoscopy, how will you do? Suppose if it is already strangulated, there is only a strangulated omentum is present, unlike any other thing. It's not an intrasil, it's only a strangulated omentum. And there is a lot of inflammatory fluid present in the abdomen. What will you do now?
So we can.
No, sir, my question was different. Dr. Rao, my question was different.
Yeah.
My question
Yeah,
was,
yeah, sir.
what are the pros and cons of laparoscopic surgery?
Yeah, that's what. Okay.
Tell me the pros and cons. If you had this hernia, what would you like to get it done by? Laparoscopic or open? Advait?
Laparoscopics.
Why? Good. Laparoscopy. Why?
So
And which approach in laparoscopy, no? Because it's an irreducible hernia. Which approach? Would you want to do TP, ETP, TAPP, what? So in such strangulated hernias,
because
TEP may be a difficult go, no?
No, let him.
No. Okay, Advait, I'll give you the answer because there are so many things. Look, what does by laparoscopic surgery? What do? You cover the MPO.
Yes.
What is MPO?
Myopectineal orifice structure.
So you cover now. By covering the MPO, what do? You prevent.
We prevent all the others.
You prevent inguinal hernia or whatever. You treat the inguinal hernia. You prevent a femoral hernia. You prevent a obturator hernia.
Yes.
You can look on the other side and see if there's an incipient hernia, and you can operate on that in the same sitting. Right?
Yes.
So the cons. Now the cons.
Surgery, which you can't do by open surgery.
Yes.
Do you get me?
Yes.
Now the cons.
Now what are the cons?
Supposing it were a strangulated hernia, and how would you approach it by open surgery? What is the difference with respect to the hernia surgery that you do in an elective setting and the hernia surgery that you do in an emergency setting? What will be the access for open surgery for a strangulated inguinal hernia?
In other words, what is the incision would you like to give?
It is the incision would be on the quad over the quad structures. It would be over the
not like that, no. So you'll make an inguinoscrotal incision.
Inguinoscrotal incision.
Or would you want to do a laparotomy? So you should not start with a laparotomy. incision will be inguinal-scrotal as against only an inguinal incision in an elective setting. Now, what else is the difference?
Okay, Dr. Ratna, I just want to ask him, why do you want to give a inguinal scrotal? Why inguinal scrotal?
What is the advantage?
One is scrotal incision because the sac, we can reach the neck of the sac.
You can reach the neck of the sac there also. Look, you want to explore the bowel, right?
Yes.
And see if there is any fluid or anything. We won't like it to enter the peritoneal cavity, isn't it?
So, what precaution do you take while the anesthesiologist is giving either GA or spinal or a regional anesthesia? You need to hold on at the neck of the sac so that the contents do not get accidentally reduced. Okay. Now, after you make an incision, what is the first step to be done once you identify the sac? In a strangulated hernia.
We would open the sac.
Where?
Where?
Where will you open the sac? At the fundus or the neck?
At the fundus.
Why at the fundus? Why not at the neck?
Because first we would like to examine the bowel.
No, because in inguinal hernia, maximum adhesions are present at the neck. While in a ventral hernia or an incisional hernia, maximum adhesions are present at the fundus. Okay, so groin hernia is opened at the fundus. What else do you achieve by opening at the fundus?
You have already answered that question. Yeah. So, which part of the hernia, the fundus you have opened? What advantage you have?
We can examine the bowel, the content if it is.
No.
So fluid,
apart from that, you can let out all the inflamed fluid through the toxic fluid through the inguinal incision at the fundus. You open the fundus. In the scrotal incision, you open the fundus of the sac and let out all the fluid, toxic fluid, so that it, as told, it doesn't enter into the peritoneal cavity. Then you start examining.
Then we would.
There's a lot of ileus and the bowel is not going in. So what maneuver will you do?
Sorry, ma'am, I couldn't hear you.
There's a lot of ileus. Bowel is discolored. What maneuver will you do in this particular case?
If the bowel is discolored, we would.
First thing is to improve the color. Oxygen. Besides giving oxygen, you would want to release the constriction at the neck.
Yes, open the neck.
So in which direction will you release the constriction at the neck? Medial, lateral, superior, inferior, where?
Medially.
Why medially? What is in an indirect hernia? What structure is present medially? You have inferior epigastric vessels, you will damage them.
Yes.
So you need to extend.
Okay, Advait.
Laterally.
Laterally.
Okay.
Advait, you reduce the bowel.
Yeah.
And the
patient,
you
will give 100% oxygen.
Hang on. The patient has gone into shock. What happened? It was a strangulated hernia. Got reduced suddenly. Or you gave the incision, the blood started flowing, and the patient goes into shock. What happened?
He's talking of a specific injury which happens because of reperfusion.
Reperfusion syndrome.
Right? And that is because all the toxins and all there
would
Yes.
re-enter
The
the
inflammatory cascade is stimulated,
yes.
is activated. The coagulation cascade is activated, and the patient goes into
Yes.
shock. Okay.
So what about mesh placement in a strangulated hernia? You have resected the bowel. It did not improve on giving oxygen, right? What are the tests of viability of bowel? What are the tests for viability
We
on the table?
would look for pallor, peristalsis, pulsation.
Okay,
Then
correct. And then you look for change in the color to pink
color.
and or normal color. You feel for the pulsations in the mesentery. Not really recommended, but you can prick and see to see if there is any fresh bleed or not. And you flick the bowel to see if there is any peristalsis or not. And you feel the tone of the bowel also, right? Now the
Yes.
peristalsis is not coming, the color is not improving. You've done resection. What are the options that you have?
Now, ma'am, we would have to do a tissue repair, and we
Oh,
cannot
after
place the mesh.
resection of bowel, what options do you have?
Tissue repair surgery,
You may
either
anastomose. If the patient's GC is bad, say because of reperfusion, ileitis, shock and all, you may get the stoma out. Invariably, you're able to anastomose because the rest of the bowel is fine. And then what about placement or non-placement of mesh?
We would place the mesh later, ma'am. It won't be in the
So
same
there are,
setting.
you should say that there are different opinions about it. There are some people who say that you can, but it may be safer to not place a mesh at this point of time. So what are the
It's
repairs
always,
that you can do if you're not placing the mesh?
yes, it depends on the contamination. So
Depending.
having toxic fluid and open the bowel, better not to, however meticulous you are, better not to put a mesh.
With mesh.
So as you told, the tissue repairs have to be done.
Yes.
Which tissue repair do you know?
We do Vessey's repair, Shoulder's repair, and McAvee's
This
repair.
repair doesn't hold here.
What are the tissue repairs of groin hernia that you are aware of? Have you heard of Vasenes? Have you heard of Darning? Have you
Telling
heard of
me.
this,
Yes,
Sarda? There are so many other repairs that you can do. If you were to use a mesh, which mesh would you prefer? You should not. But if you were to use it, which one would you use?
Suppose in the same setting you need to put a mesh. Which mesh do you prefer?
You should know about absorbable meshes.
Bioabsorbable
Right?
meshes still is not popular in India. Just using, some people are using, but not very popular.
Yeah.
Yes.
So what are the complications that can happen after a hernia repair?
after a hernia repair, man, there can be hematoma, nerve injury,
Sorry?
recurrence can.
Recurrence is late, so you will talk about early and delayed. What are the
Yeah.
immediate early complications that can happen?
Hematoma, seroma, there may be
Yes.
nerve injury, pain,
And if mesh has been used, mesh
another
infection and SSI,
SSI.
right? Delayed would be recurrence. How do you
Recurrence.
manage mesh infection?
Managing SSI, ma'am?
How do you manage mesh infection?
Mesh infection. We would remove the operate
So
again and
not every time, no? You need to see whether it is superficial, whether there is superficial SSI or deep SSI, and accordingly you will manage. In deep SSI, if there is a collection needs to be trained. If it doesn't improve, then you need to consider partial excision or a complete excision of the mesh. What is the difficulty that you encounter when you need to take out the mesh? See, if the mesh is floating in pus, it is not a problem, it will come out. Otherwise, it may be embedded and it may be difficult to
Embedded.
take out.
Yes.
Yeah.
So
What
what
about the
other
role of
complications do you
antibiotics?
have?
Hmm.
What other complications you can have? Late complications.
There will be ischemic orchitis, testicular atrophy, then
Okay. Apart from that, because of mesh, any complications can occur?
mesh. The mesh can get displaced.
Mesh displacement. Okay. When open hernias, very rare.
Nerve entrapment.
What is inguinal?
Chronic chronic inguinal herniorrhaphy pain. It would occur because of resection, because of nerve entrapment.
Entrapped between?
The mesh
Hmm?
by suture.
Not sutures.
In
So
the
it
mesh
is
section.
usually in the crevices of the mesh, there will be lot of fibrosis. The nerves itself, they get entrapped by the fibrotic material, fibrotic plate, it is called fibrotic plate, and they'll have an inguinal.
What is the role of antibiotics in hernia surgery?
It is a clean surgery, ma'am. So if it was a emergency surgery where bowel resection or contamination is there, then we would give antibiotics.
Till how much
Or
period
prophylactically we can give
for how much till what duration of time will you call it SSI when it comes to hernia repair? So mesh is an implant. So for every implant, you wait for a period of
1 year.
So I stand corrected. I thought it was. Huh? Hello, yes, would anyone else want to take it? I stand corrected. I thought it could be till a period of. Hello.
Yes,
I think
madam.
it is for 1 year. The mesh, till how much time can we call it SSI in hernia in which mesh repair has been done? You're correct. I think it is 1 year. Yeah.
Not sure.
No. SSI, it's not for 1 year, madam.
Implant-related
Then
will
it
take
is for,
1 year.
it's
Any
for
infection
for
within
more.
1 year is taken as SSI. Yeah.
No, madam. I'm not sure.
So I think we can call
No,
it a day
regarding
for this
the
case and move to the next.
laparoscopic repairs, are we
Yeah.
done with the? I mean, I think it's already 9:10. Can
Yeah,
we
I
go
think
for
we
the
should move
second
to.
case?
Yeah,
Go
we
for
should
the
move
next
for the
case,
next.
sir.
So but
Yeah,
you must know about triangle of doom. You know what is the circle of death?
Yes, ma'am.
What is circle of death?
It is the corona mortis, ma'am, where
What is corona mortis?
the aberrant obturator artery would be present.
Can there be circle of death due to veins also? So there are
No,
veins of Pendavid that are present here, right? In the same
Okay.
location. So they can also lead to massive amount of bleeding. Like what is the lower limit of dissection in laparoscopic hernia repair?
The
So lower
ileocecal
limit is
tract,
when the vase turns medially. Okay. What is the lateral limit?
the ASIS,
Till you see the psoas, right?
till to
What is
see.
this? What do you say? What is the difference between inguinal ligament and iliopubic tract? Is
The
iliopubic
inguinal
tract a
ligament
real structure or is it a virtual structure?
is a real structure, ma'am. The inguinal ligament is
No, are they the same? Are they different?
They are different, ma'am.
What is iliopubic tract?
Iliopubic tract is made up of
It
the
is the thickening of
transverse
fascia transversalis, which is
fascia
present at
transversalis.
the same level as that of inguinal ligament, but on the interior aspect. Okay. What is the importance of this iliopubic tract? Technical importance.
So
You
what
do not
should not be done below that level?
below that.
Fixation of the mesh.
Yeah, because it can cause many complications, right? So triangular pain, triangular doom we should know about. I think more or less we've covered, but there's lots to cover in groin hernia. So you need to know about newer procedures, advantages of ETP, right? What is ETP?
What is ETEP? Just give an expansion, that's enough. ETEP.
Sorry, sir.
ETEP. ETEP.
Is extended totally extraperitoneal.
Extended view. Extended view, totally extraperitoneal repair.
Extraperitoneal repair. Yes.
Yeah.
I think we call it a thing of presentation, but there's a huge scope of improvement, right? Right, in terms of knowing about the basics about the physiology and the anatomy of hernia, as well as the recent repairs. Okay?
Yes, ma'am.
Yeah.
So, okay, you have done well, but yeah.
Yeah. So could you just assess his performance, Dr. Ratna?
Yeah, he's good, sir. He is good. He's stable. He answered well. Little, as madam told, little needs.
If I were to mark him, I would, to be honest, I would give him 5 out of 10. Right? You would pass because you knew the basics, but then you need to know more about it. Because if you just pass in one case, then, and if you do not do well in the other, then you can succumb. Right? So we must take it very positively and realize the areas where there is scope of improvement. Very well done otherwise. And it is good that you were a bold person to make a presentation at a national level. Keep doing it.
If he has done 5 out of 10 at national level of presentation, he'll do 8 out of 10 in local presentations.
Yes.
Definitely in exams he'll do it. Okay, all the best, Advait. We'll move on to the second case, sir.
Yeah. Just a second. This is on CA tongue. I don't know who's opening it. Just let me open this.
Good evening, sir.
Okay. Sorry, Sairaj. Yes. Sairaj, is that you who's presenting the case on CA tongue? Yeah. Could you share your slides, please?
Yes.
Rajiv, sir.
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 I can't hear. Sir, I can't hear you.
Sir. Sir, if you excuse me, I have an important meeting.
Sir, please, sir. That's fine.
Yeah. Sir, Kanavel, sir. Good night, sir.
Sir, we are okay, sir. I think we have Dr. Sairaj available here. Dr. Sairaj?
Yes, sir.
We always speed ourselves up.
Okay. Will you please share your PowerPoint, Dr. Sairaj?
Yes, sir.
No one does open surgery. Everything's endovascular. In fact, when it's a hard case, they actually they'll spend 8 hours.
Thank you, Dr. Advait.
Estimating costs or estimating these issues.
Sir, good evening, all the sirs and ma'am. Myself, Dr. Sairaj. I'm post.
We are yet to see your presentation, ma'am.
It's cheap, but most of it was a big draw in open surgery.
So we can hardly hear you, and we cannot see your presentation at all.
Money, savings, healthcare is willing to invest.
Sai.
Sir, it's coming. Yes, sir.
Yeah.
Hello?
We can hardly hear you.
Hello, sir. Can you?
And we cannot. Yeah, that's better.
Yes, sir. Sir, can
No,
able
we
to
don't
see
have
the
your
presentation,
presentation.
sir?
Right?
No, sir.
Yeah, we do a lot with video consult. So you 20,000, another 3 million extra dollars that we spent to make sure.
Sai.
Are you able to share the
Yes, sir.
PowerPoint, Sai?
Sir,
Yes,
I'm
it's
sharing it.
very possible because, right, it's
Yeah, please.
planning, right? Oh,
Sai, what is the challenge we're having, ma?
It's showing like that, sir. Like it's coming in my laptop, but
No,
I
no,
don't know
no.
whether
Please,
it's
no, you just accept the Zoom. Please close down all the windows. Just follow my instructions.
yes, sir.
You have shut down except Zoom all the windows.
Yes, sir. Can you shut down?
No, no, no. Please close all the windows.
Yes, sir.
All right. Now, in the Zoom window, can you see a share screen button?
Yes, sir.
Press that. What are the things you see there?
I'm saying
Share desktop or share full screen. Do you see some that mode?
yes, sir. Entire screen, yes, sir.
Yeah, yeah. Press that mode.
Yes, sir.
Have you done that?
Yes, sir.
Now open the PowerPoint. Yeah, make the PowerPoint into the full screen. Faculty, apologies for this confusion. He had some challenges earlier, so he had to change the device. I think now things are fine. Dr. Sairaj, you please introduce yourself, your teacher, and then the head of the department, and start your presentation.
Yes.
Good luck.
Sir,
I think are
good
you
evening.
enabled screen recording or something?
No, sir.
You please, yeah, close that, please.
Yes, sir. Yes, sir. Close.
Good luck to you. Faculty, apologies, and please take over. Thank you.
Thank you. Good evening, everyone. Myself, Dr. Sairaj. I'm postgraduate second year in MS General Surgery in Madras
Please
Medical
be
College.
loud and clear.
Myself, Dr. Sairaj. I am doing MS General Surgery in Madras Medical College under the guidance of Dr. D. Durai sir, MS D. Arthur, and Director of In Charge in our Institute of General Surgery, Madras Medical College. Today, I am going to talk about a case presentation in CA tongue. A 35-year-old male, Mr. X, who come from a village in Vellore, working as a clerk in post office, belonging to low socioeconomic status, came to a surgery OPD with complaints of an ulcerative growth in the tongue for past 1 month. The patient was apparently asymptomatic 1 month back, after which he noticed an ulcerative growth in the left lateral aspect of the tongue, which was insidious in onset, which at the start it was a small peanut-sized swelling, which gradually progressed and ulcerated to form an ulcerative growth of present size, for which a biopsy of taken 1 week back in our RGGH. The patient also complains of associated pain for past 15 days, which was intermittent in nature and pricking type of pain, non-radiating, which was aggravated by taking foods. The patient also had a left ear pain for past 15 days. He also had difficulty in speech, and he complained of voice change and halitosis. The patient also had difficulty in protruding the tongue out, and he complained of excessive swelling and difficulty in swallowing also. The patient had no history of loss of taste sensation, no history of difficulty in opening the mouth, no history of discharge, no history of LOA or LOW, no history of recent trauma or no history of loose tooth, no history of recent falling of tooth, no history of chest pain, hemoptysis, no history of idiopathic swelling. A past history, the patient doesn't have any previous significant surgical or medical history. The patient doesn't have any previous ulcers in its oral cavity or any history of tooth removed in the past. The patient doesn't have any tooth dentures, no history of any STDs, no history of any previous radiation to the neck. Family history, no history of any other malignancy in his first degree relatives. Personal history, the patient history of using horns for past 15 years. One pack which lasts for 4 days. The last use of horns was 1 month back. The patient also gives history of alcohol intake for the past 15 years. Usually takes 180 ml per day. Last binge was like 1 month back. The patient also has a history of taking spicy food intake and mixed diet. No history of smoking or retail food chewing. The patient had normal bowel and bladder habits. Summary: a 35-year-old male from a low socioeconomic status with history of chronic arms use and alcohol intake and spicy food intake presented with complaints of ulceroproliferative growth in the lateral aspect of the tongue for the past 1 month, associated with pain, referred pain to the left ear, halitosis, excess salivation, difficulty in swallowing, speech, and tongue movement.
Yes, so based on the history, what do you think are you dealing with? A benign process, a malignant process, or what?
From the history, the patient have a sudden swelling, which is also proliferative, and the patient also has a complaining of referred pain to the left ear. I usually go to the first.
Be loud. I'm having to strain to listen to you. Be loud and clear.
Yes. But by his complaints for the past 15 days, he have ulceroproliferative growth, and he also has a referred pain to the left ear. So I usually my first diagnosis will be a CA tongue.
So you say that he seems to have an ulceroproliferative lesion with history suggestive of this is a high index of suspicion of malignancy due to the risk factors that are there, right? Besides the risk factors, there is difficulty in protruding the tongue and other features like referred pain, which are pointers towards malignancy. Now, if we go back to your first slide, you know, in history taking, it is good to give it in patient's own language. To say that patient complains of something on the lateral surface of the tongue and an ulceroproliferative growth, you can in fact say that on the side of the tongue, right or left, and that he complained of a nodule first, which ulcerated thereafter, right? Or it could have been an ulcerative growth, which proliferated later. There's a difference between a fungating mass and an ulceroproliferative growth. What you're talking about is a nodule which ulcerated later. So that does not become an ulceroproliferative growth. No? Ulceroproliferative would start as a raw area and then proliferate. While a fungating growth will start as a nodule and thereafter ulcerate. Am I right?
Yes.
Yes? And so be careful about what you are speaking. Right? In the history only you can talk about whether on the side also it was present towards the tip of the tongue on the lateral side or towards the posterior part of the tongue. Where was it present?
It was on the lateral side of the tongue, not on the posterior
side. The lateral side is the side of the tongue. Now that side also can be towards the anterior aspect of the posterior. So what is
Anterior.
the importance?
Ma'am,
So
anterior
which part of
aspect,
the tongue is, are we dealing with oral cavity malignancy? Are we dealing with oropharyngeal malignancy?
oral cavity malignancy.
Why do you say that?
Because the posterior
Because
part.
if anterior, yeah. Yes, please.
Yes.
So if anterior two-thirds of the tongue is involved, then you're dealing with oral cavity. If posterior part is involved, it comes in oropharyngeal malignancies, right? Why did
Yes.
you take this loss of teeth?
Because if any sharp tooth, long-standing
No, it
injury
has
to
to
the
be, you have to talk about unexplained loss of teeth, right?
because
He did
of
not
involvement
undergo
of alveolus.
extraction. So what happens? Why do teeth get lost in some malignancies of oral cavity?
Malignancy involved to the alveolus, which leads to loss of teeth.
Sorry?
Malignancy
What did
which
you
is spread to the cancer lesion which is spread to the alveoli of the mandible, which
No,
leads to
not
loss of
directly to, no, that's not correct. Not to the alveoli. Malignancies that spread to the medulla of the mandible, no, the marrow of the mandible. If marrow involvement is there, then the roots get destroyed. And that's how there is unexplained loss of teeth. Patients can become edentulous also because of that.
Yes.
Right?
Yes.
Yeah.
Yes.
So what
Okay,
about
Dr.
mouth
Sai.
opening? Was he?
Yes.
Please.
What about mouth opening? Was he able to speak normally? Could you open his
Yes.
mouth?
Ma'am, he has difficulty in articulation, but he is
Sorry?
able to open his mouth. He has difficulty in articulation, but he is able to open
Yes.
the mouth completely.
What do you think is the cause of earache?
Ma'am,
What is the
earache
cause of
usually
earache?
it is usually due to spread to the trigeminal nerve, which it's a referred pain spread to the
Why
trigeminal
is
nerve.
it a referred pain? It is referred pain due to involvement of which nerve?
Submandibular. Submandibular nerve,
Not
which
at
is
all. It is because of auriculotemporal nerve involvement, and the nucleus is the same in the brain.
Yes.
Right?
Yes.
So that's why it is referred.
Yes.
Yeah.
Okay, Dr. Sai, your patient is 35 years old. Let's go to your first slide.
Yes. Yes.
You think it's kind of early to have carcinoma, oral cancer at 35? And
It's usually in middle ages.
so why do you think he has any? What could be the cause of this cancer at age of 35?
The patient has a chronic history of taking arms, which is a predisposing factor for
All that
development
is
of.
fine. They all have these predisposing factors. But is there something else? When do you find a patient having carcinoma at an earlier age? They all smoke, they all drink, they have alcohol, they all have this betel nut and all that tobacco chewing and all that. Still, this fellow's at 35. Any other factor which you're missing? HPV.
Yes.
Okay, HPV patients tend to have it earlier. Now, how does an HPV malignancy differ from a non-HPV malignancy? In oral
HPV
cavity. Yeah.
Usually warty lesions will come first in HPV lesion.
You don't get warts in the mouth.
Yes, sir, warts in the mouth and
They're
which
typically
causes
described as strawberry proliferation. Right?
And you need to know
And in
that the
the
prognosis of HPV related malignancies is better as compared to non-HPV. So they are classified separately. Which strain of HPV?
usually 16 and 18.
Yeah. Yeah.
okay. And HPV lesions are usually noted At the base of the tongue or at near the tonsils?
Usually near the tonsils, sir.
Yes. Okay, you said that he's got pain in the ear because of which nerve?
The auriculotemporal nerve,
Is the, yeah,
which is a branch of
lingual nerve through
trigeminal.
auricular temporal nerve.
Auriculotemporal.
Now, suppose he comes with a pain in the pharynx, oropharynx.
Yes.
Which nerve would have been involved, and where would the lesion have been?
Vagus nerve.
Glossopharyngeal. Not vagus, glossopharyngeal. So at the base of the tongue, at the posterior third of the tongue, is glossopharyngeal. Okay.
What is the importance of smoking and alcohol in oral cavity malignancies?
Taking alcohol binges usually, they also usually take spicy foods along with it.
See, individually both cause malignancy, but they have a synergistic effect when taken together.
Yes.
How does alcohol cause malignancy?
They take spicy foods with it. So
No, we're talking about alcohol. How does that predispose to malignant change? Produces aldehydes, they break the DNA, and the breaking of DNA leads to predisposition to a malignant change, right? So there's a genetic change thing related to it.
Yes.
Okay,
So what
Dr.
is Indian
Sai,
cancer? You said betel quid he used to keep in the mouth, right? And we said he smoked betel quid also. What is Indian cancer?
I can't able to get it.
So Indian cancer is a specific entity wherein they
Yes,
keep
Indian cancer is
squid
usually
between the in the gingival labia. Gingival cycles. Yeah. So it is supposed to have a relatively good prognosis again.
Yes.
Okay.
Yes.
Okay, Dr. Sai, next slide, please. Next slide. You said something about peanut.
Yes, sir.
There's nothing called peanut size here. Just mention the size approximately, as gestured by the patient. What would be the peanut size? It would be 1 centimeter. So say 1 centimeter. Why peanuts and coconuts? Okay, about alcohol. How does alcohol in this case? Ma'am said it's synergistic. They help each other. How does it help? What does alcohol do in this case when he's having betel nut and chewing tobacco and smoking away? So it dissolves the carcinogens, right? And this is what is field cancerization then?
What is field cancerization?
Yeah, please.
And who gave this name? So field cancerization is when in the adjoining mucosa also you find changes that are suggestive of malignancy, wherein the etiological cause is the same, right? That is field cancerization. I don't remember the full name. I think somebody by the name of Slaughter who gave this name. Field cancerization.
There may not be florid malignancy, but there'll be dysplastic changes. Okay, yeah. Yeah, Dr. Ratna,
and
please.
which leads to development of second primary later. That is why it becomes important. So you need to investigate for presence of a second primary in the same patient.
Synergistic lesions.
Yeah. These are causes of difficulty in speech.
Yes.
What are the causes of difficulty in speech?
Usually due to muscle involvement, extrinsic and intrinsic.
It can be due to movement of the tongue may be affected due to involvement of the intrinsic and the extrinsic muscles of tongue. You said there is difficulty in protrusion also, no? Right? And then by virtue of it occupying a volume or space within the oral cavity. So the movement will get affected because of that also. So which leads
Yes.
to change in voice. Then involvement of the cranial nerves may lead to all this. Okay?
Yes.
Yeah.
Yes.
Okay, Dr.
Halitosis,
Sai.
you know about?
Yeah. Please, Doctor.
Yes, Dr. Sai.
No, go on, please.
Yes.
Move to the next slide.
Okay, let's talk about halitosis. What is halitosis?
Sir,
What is
foul
halitosis?
swelling breathing, which is usually due
So why do you get
to
this foul smell? Why do you get this foul smell?
usually there will be central necrosis will be there, sir, and dead tissues will be there, which causes a halitosis. Foul swelling.
Is that so?
And also the patient have excess salivation, and the patient also have difficulty in swallowing.
No, salivation is not to do with halitosis. Salivation will work. It is because of the bacteria and
Poor
the
oral hygiene. Poor
necrotic
oral hygiene
tissues.
also.
They all release. What do they release? Mercaptans. Okay.
Yes.
They are the ones which cause here. Okay.
Yes.
You said about protrusion of tongue. We've discussed excessive salivation. Why?
Yes. Yes.
Why excessive salivation?
So the patient have difficulty in swallowing, sir, which leads to
Okay, one is difficulty in swallowing.
the patient
Second,
swallowing saliva also, sir. Second is
second,
due to irritation which causes excessive salivation.
right. The nerve fibers are irritated, and that leads to.
Nerve fiber, yes, which
So
causes.
you find a patient in your OPD. If you find a patient in OPD with a handkerchief in his hand and spitting all the time, you know it's
Yes.
malignancy. Okay.
Yes.
Okay.
Why did you ask for these
Mm.
chest complaints?
To see for metastasis, whether the patient have any
Do they metastasize to the chest? You think oral cavity metastasizes to the chest, to the lungs?
not to the lungs, sir.
What is more common?
Body metastasis. Body
What is
metastasis.
more common?
Basically, you know, patient may aspirate, and due to which there are recurrent lung infections. That is the reason why you take this history. Okay.
Yes.
During
What is this
sleep, you
LOA
can
and
aspirate.
LOW? Sorry, what is this LOA,
Sir,
LOW?
loss of appetite and loss of weight.
Please use
Don't you?
anagrams which are acceptable. Loss of appetite and loss of weight is not LOA and LOW. Never heard of it. It may be Madras MCC centric. Use a standard one.
Yes.
So why did you take history of recent trauma?
Ma'am, as it's an ulcer in the tongue, so we suspected.
Hang on, Sairaj. Is it recent or is it chronic?
Sir?
What is more
Since
important, recent
trauma
trauma or
patient
chronic
tongue
trauma?
is such a vascular structure.
Chronic is more important.
Then you're writing recent, and you try to explain also.
The
No, sir,
patient
to
will bleed
rule
to
out
death.
whether any benign conditions like recent trauma to the tongue, which causes ulcer in the tongue, like that. To rule out the pain.
To rule out?
To rule out
I can't
some
hear you.
recent trauma to the tongue. As it's an ulcerative lesion, ulcerative lesion in the tongue.
Yeah.
The
Yeah.
patient also has the bleeding, so we want to rule out the patient had any recent
Oh, please
trauma to the tongue.
don't Sairaj, don't stretch it so much that it sounds ridiculous. He's got ulcer proliferative, so he's got trauma, so he'll have bleeding. Yeah, we are talking malignancy. What are the causes? Chronic irritation, chronic trauma. Recent trauma has got nothing to do with it. Just go back on your back foot and accept it. Yeah, go on, Dr. Ratna, please.
What is trismus? What is trismus?
Difficulty in opening the mouth.
It is so difficult. Why didn't you come closer and speak? No? Yeah. What is
difficulty in
trismus?
opening the mouth. Difficulty in
Yeah, what
opening.
are the causes? What do you think are the
No,
causes in such a case?
Submucosal fibrosis.
Okay.
Due to which
No, in this case, Sai, In this case, it's because of submucous fibrosis.
The patient doesn't have submucosal fibrosis, so the patient able to open no history of fibrosis.
Okay. Okay. How do you know this patient doesn't have submucous fibrosis?
Sir, the normal opening of mouth is 3.5 centimeters. So able to insert 3 fingers in his mouth.
So if the patient has malignancy, he can open his mouth normally.
No, sir,
He can't open his mouth completely, only in case of SMF.
One is pre-existing submucosal fibrosis. What are the other reasons? You said he's got difficulty in protrusion of tongue also, no? So it may have involved laterally some muscles. Which muscles are important for?
Genioglossus.
Genioglossus is lateral.
Genioglossus. Why should that leads to protrusion? With that is not responsible for opening of mouth, no? So which muscles will be responsible for opening of mouth? You need to talk about.
Sigh, don't get psyched. Don't get hassled. Just think, what are the muscles? Yeah.
Pterygoids. Yes, pterygoids.
Right. And masseters.
Masseter. And then in advanced malignancies, involvement of temporomandibular joint. Okay?
Right.
Yes.
Yeah. Neck swellings, I suppose you know. Why did you ask for history of any swelling in the neck?
To rule out any synchronous neck lesions. To rule out any secondary swelling, like synchronous neck
secondary is where?
In the neck.
In the lymph nodes in the neck, right? Yeah.
Any lymph nodes, yes. Lymph nodes.
Dr. Sai, can we move to examination?
Yes.
Yeah. Just the next slide, please.
Yeah.
Past history. The past history.
Yes.
Okay. So what do you think clinically? What do you think you're dealing with?
Well,
clinically, what do you think you're dealing with?
Sir, clinically, it looks like we usually rule out malignant causes first. So it's
rule out. Sorry, we can so clean.
Sir, clinically we are dealing with the CA tongues.
Yeah, probably a malignancy of the oral cavity.
Hello, sir.
Okay.
Yes, sir.
Okay. Let's go to your examination. Quick.
Yes.
Yeah. So let's move to examination.
Yes.
What is this Hans usage?
What?
What is this HANS usage?
Hans means tobacco. It's a kind of tobacco. Usually, the people keep in their mouth. Besides,
okay.
Arey Baba Sai, use terms which are universally acceptable. Yeah, Hans, you don't understand this here.
Yes.
So you can say the patient does not take tobacco in any form, whether it is oral or in the form of smoking or inhalation. And then you may use these terms. If you are asked that what did you ask, then you can talk about these local terms also. Yeah.
Yes.
Proceed to examination.
On general examination, patient is cooperative, conscious, oriented to time, place, and person. Patient is afebrile and his temperature was 96.6, 98.6. He got was 1. No pallor, icterus, cyanosis, clubbing, pedal edema. The patient had halitosis and poor oral agent. His hydration is fair. On local examination, after getting informed consent from the patient is examined in a well-lit room in a sitting position using a spatula. On inspection, an ulcero-proliferative growth of size of 5 × 4 cm present over the left lateral aspect of the neck, which is irregular in shape extending from the tip of the tongue to the tip of the tongue anteriorly, medially from midline, inferiorly extending into the left floor of the mouth, ill-defined margins and raised edges. Floor is formed by necrotic tissue and slough. Mobility of the tongue is restricted. Able to protrude the tongue. Tongue is only up to the level of the lip. No evidence of deviation of the tongue. Whitish flakes present over the rest of the tongue. No evidence of fissures, cracks in the rest of the tongue. Mouth opening was normal at which three fingers, 4.4 centimeters. Lip, hard palate, retromolar tribune are normal. Buccal mucosa is normal. Gingival-buccal sulcus normal. Gums alveolus normal. Nicotine stains over the teeth are present. No evidence of sharp tooth or dental caries present. Anterior tonsillar pillar is hyperemic. Tonsillar pillar, posterior tonsillar pillar, uvula are normal. On palpation, inspectory findings are confirmed. An observed proliferative growth of size 5 cross 4 cross 2 centimeter present in the left lateral aspect of the tongue. Irregular in shape, extending from the tip of the tongue anteriorly, medially from midline, inferiorly extending into the floor of the mouth. On the left side, ill-defined margins, raised edges, tenderness present over the ulcer proliferative growth. The base is indurated, which is about 0.5 centimeter around the ulcer. The ulcer does not bleeds on touch. No mandibular thickening or irregularities. No mandibular tenderness present. No evidence of involvement of deeper structures. Skin over the face and submandibular region appears normal. Its dentition, right upper 2, 1, 2, 3, left upper 2, 1, 2, 3, right lower 2, 1, 2, 3, left lower 2, 1, 2, 3. On examination of the neck, on palpation, a 1.5 cross 1 centimeter lymph node swelling present over the level 2 on the left side. Firm in consistency, it's not tender. The lymph node is mobile, no evidence of other enlarged lymph nodes present. Bilateral carotid pulsation palpable, and both are felt equally. On systemic examination, TVS S1, S2 present, no murmurs. RS bilateral air entry present, no added sounds. On per-abdominal examination, abdomen soft, bowel sounds present, not tender, no palpable mass. On CNS, bilateral pupils equally reacting to light. Summary: a 35-year-old male with history of chronic alcohol and arms usage, tobacco usage from low socioeconomic status with complaints of ulceroproliferative growth on the tongue for the past 1 month, associated with pain on swallowing and speech disturbances. On examination, and also proliferative growth of size 5 cross 4 centimeter over the left lateral aspect of the tongue, with extension into the floor of the mouth and restricted mobility of tongue, and palpable mobile lymph node, a single lymph node of size 1 cross 5, 1.5 centimeter cross 1 centimeter at the level 2 present.
What is your diagnosis? What is the diagnosis?
CA carcinoma tongue. Clinical diagnosis with a clinical staging of CT3, N1, N0.
Let's go to your examination. Regional examination.
Yes.
Sai, yeah. A few slides previous. Okay, that's fine. That's fine.
What have you told us about the sensations over the chin? What have you told us about the sensations over the chin?
And sensation, the patient have a normal taste sensation. Taste
So
sensation.
what is
The
the
patient able to
importance?
Huh?
You need to you need to make a conscious effort to look for them, because this, it tells you about the involvement of
patient.
which nerve?
Lingual nerve, which is a branch of facial nerve.
There's
No,
a
no, no,
nerve.
no.
No.
Marginal. Sai,
No,
marginal.
not marginal. No. Inferior alveolar
Marginal
nerve is
mandibular.
there. This is
Marginal mandibular nerve, which is a branch of facial
Yeah.
nerve, which
nerve within the mandibular canal, and through this mental foramen comes out the nerve which gives sensations to the chin, right? So they get affected. You also need to make a conscious effort to look for a facial lymph node here, which you've not talked about. You said it is involving the floor of the mouth, and then you said it is not involving the deeper structures. What do you mean by that?
But because the tongue usually have skip lesions. So
no, what I mean to say is that you said that it's a lesion in the tongue and it's involving the floor of the mouth. Then you said that it is not involving the deeper structures. The very fact that it is extended from one area of oral cavity to another area means it is a locally advanced disease. Right? Yeah.
Yes.
And what about whether it is crossing the midline or not?
no, it's not crossing the midline.
Yeah. So you said it's extending, I think, till the midline. But you must make a specific mention of the fact whether it is going across the midline also or not. Because you said there is induration which is extending beyond it. So if the growth is till the midline and there is induration beyond, then that means it's going beyond the midline. Okay? And you said there are whitish patches which can be scraped away. What are these whitish patches? What are these whitish patches that you said can be scraped away easily?
Yes, it's those are plates.
So what we want to know is that are we dealing with leukoplakia or are we dealing with candidiasis? So if you can scrape them away, what are they?
Candidiasis.
Candidiasis, right? So you said poor hygiene, probably it could be. Now, which type of candidiasis can lead to malignancy? So there is this hyperplastic variety of candidiasis, which can lead to malignancy. Okay. So now, what about leukoplakia and what are the grades of leukoplakia?
Leukoplakia, nodular, and the speckled types are there.
So you need to know, no, it is just a white thickened plaque, white patch, white thickened plaque, then thereafter
Nodular type.
nodular, what else?
Size. What's the size?
Yes.
More than 5 millimeters.
Okay.
And then it can have that aluminium paint appearance also, right?
Yes.
Then
Yes. And the speckled.
what else?
Speckled.
What is
Speckled type.
erythroplakia? What is erythroplakia?
Erythroplakia. Reddish.
Reddish patches. And you can have a
Reddish
combination
patches.
of these. Then you need to know about melanoplakia also. What is that? Black patches. Okay. So all these have to be looked for, and where all they are present have to be seen and mentioned. Dentition.
Okay, Sai, I'll just ask you one question. Sai, what are the factors which turn a leukoplakia into malignancy? What are the factors? How much percentage of leukoplakia turns malignant? Only about 1%. So now what are those factors?
Speckled
Which is the most
leukoplakia
important factor?
Speckled leukoplakia, which is more chances of
Non-homogeneous, okay. Non-homogeneous or speckled, okay, fine. What else? Long duration, more than 2 centimeters, right?
Yes.
These are long
What is the-
duration is
what
one of
is
the
it?
biggest.
Yes,
Suppose the
long
patient had just leukoplakia. How do you manage leukoplakia? What do you do?
the, laser treatment can be done. First, we have to avoid the risk factors.
Exactly. You get rid of the risk factors. Usually they go off on their own. Right. If they persist.
Lifestyle modification. Lifestyle
Right.
modification.
You said there is something on the tonsillar pillar, redness or something. Next slide, please. You said something about tonsillar pillar, red side. Anterior tonsillar pillar hyperemia. What do you mean by that?
It shows a reddish. So
what is the significance? What does it mean? What do you want to convey?
So the lesion is spreading.
Is it more red than the other areas? Why should just one tonsillar pillar become hyperemic? Is it erythroplakia?
No, sir. The patient had a candidiasis also, which causes.
He had a
candidiasis, oral candidiasis. So
oral candidiasis.
Yes, sir. The patient also had oral candidiasis.
I can't hear you. Sorry, I can't hear you at all.
So the patient had oral candidiasis, sir. And
so why this hyperemic? You said you've not mentioned a candidiasis anywhere in your examination.
I have mentioned that scraping of.
He's written whitish patches which can be scraped easily.
Okay, that's fine. So, but why is this hyperemic then? I can't understand. Look, Sai, you don't have to. If you don't mention it, it's not going to do anything. It's not going to change your diagnosis. It's not going to change your management. It's going to not change your marks. Don't put in things which are irrelevant. No clinical significance. How can we just one pillar become red and all others are normal? Do you get me?
Yes.
Yeah, Dr. Ratna, please, ma'am.
What is this inverted curtain sign? So you look at the arches of the soft palate, right? If one is hanging loose and flattened, it is due to involvement of glossopharyngeal nerve, right? What are the cranial nerves that you must examine in a patient of oral cavity malignancy? And why must you examine them?
Cranial.
So glossopharyngeal, facial, hypoglossal, spinal accessory, all of these vagus, all these need to be examined, right? Because they can get involved if the neck is involved or if the base of the skull is involved, right? So you need to do cranial nerve examination also in a patient of oral cavity malignancy, right? So what do you mean about looking for mandibular thickening? So because it is above the floor of the mouth, it can extend to the inner table of the mandible also. And if it involves a mandibular canal, there can be widening of the mandible. So that is why it becomes important to examine the regional areas also. Right? And again, then you look for field cancerization, right? On clinical examination and extension of clinical examination, like direct and indirect laryngoscopy and so we'll come to that later. Move to the next slide. Does the involvement of alveolus mean involvement of mandible?
No, there is no involvement of mandible.
It does not, okay? It does not change the stage. Does the involvement of periosteum mean that you need to manage the mandible surgically?
Yes, ma'am.
It
Yeah,
does
we can
not.
do.
It does not. It is only if the cortex or medulla of mandible are involved that you need to consider management of mandible. Okay?
Yes.
Otherwise,
Yes.
periosteum can be peeled off. Yeah.
Yes.
Move to the next slide.
Yes.
So, what is the technique of examining the posterior part of the tongue?
Indirectly.
It's an uncomfortable procedure to do, but then you can digitally palpate the posterior part of the tongue. But because it causes gag reflex, it is usually not done. Dentition you've mentioned is complete. Yeah. So how will you manage this case?
So we can go for the.
See, let me tell you, 20 times we've told you it's difficult to hear. After some time, the examiner will stop taking interest in what you are speaking. So make yourself heard.
Yes.
Yeah.
Sai,
We usually go
Sai,
for,
before we go, Sai,
Yes, sir.
did you do a bidigital examination of the tongue? Could you assess the depth?
Yes. Yes, sir. It's
So have you mentioned
0.5. Yes, sir. I mentioned 0.5 centimeters.
How can you measure 0.5 millimeters? My question is the superior and the inferior surface both involved? Is it through and through? Or is it just
Yes, sir.
the upper half of the tongue? So the whole of the tongue is involved on that side, isn't it?
Yes. Yes, sir.
So why is it 5.5 millimeters then?
Sir, it's like
Depth
1 to 2
is the
centimeters.
depth of the tongue. So you got to do a bidigital examination and see where the induration ends. Have you seen where the induration ends? Look, the ulcer in the tongue is not the end of the story. The induration. You have to know
So
the
you
extent of
mentioned
induration
that
also.
base induration is present 5 centimeter, around 0.5 centimeter, around the ulcer. What is the importance of this induration?
The induration up to depth of up to which depth the
It doesn't tell you about the depth. It tells you about the extent of involvement.
extent.
Okay, so induration means it is basically because of desmoplasia and is taken as malignancy. So the margins that you will take will be beyond that. So with respect to the dentition, you should have mentioned what is the posterior extent of the ulceroproliferative growth. Right? So posterior extent also, how far posterior it is going needs to be mentioned. Okay, medially you said it's up to the midline, but how far posteriorly also you need to mention.
Yes.
Yeah. So now let's move to Dr. Sai. Any other question? I think we can move to management. Management. What is this edge wedge biopsy and where will you take it from?
We usually take it from the tip of the. It usually covers the normal tissue and also the
what do you mean
cancerous
usually? No? So you will take it from the anterior part and not the posterior. Why?
Anterior tip of the tongue. Anterior part
Why?
of the tongue.
Why anteriorly? Why not posteriorly? Because it will change the posterior limit of your excision, no? Once you take a biopsy from there, right? And plus, it is more likely to cause complications if it's far too posterior beyond what?
Behind the sulcus.
Huh? You're in the junction of anterior 2/3 and posterior 1/3. Okay? Yeah.
Yes.
So,
About management,
what about lymph nodes in the neck? Would you want to FNA them?
yes, ma'am. FNAC of the lymph node can be done to find out.
So usually you do not. You give them a course of antibiotics and see if they resolve or not. Improve the oral hygiene of the patient. Okay, so why do you want to see CT neck and MRI oral cavity?
The MRI is used to done to find the depth of invasion.
Sorry?
Depth of invasion.
Hmm.
To find the depth of invasion.
It's
CCT
going
neck
from.
to CCT is to rule out neck lymph nodes.
Why indirect laryngoscopy? So in today's date, you can do a direct laryngoscopy and see, right? Yeah.
Yes.
Please move to the next slide. What is your plan of management for this patient? So you've taken a biopsy and it turns out to be squamous cell carcinoma.
Yes.
How will you proceed?
We will go on with hemiglossectomy.
Sorry?
And modified hemiglossectomy with modified radical neck dissection.
With modified radical neck dissection.
Radical neck dissection. Yes.
Radical neck dissection. What is that?
Modified radical neck dissection.
What is that? What kind of modification?
We will preserve the
unilateral, bilateral, what? Unilateral, bilateral. Huh?
Unilateral.
By unilateral. Why in tongue you should do a bilateral selective block dissection involving which group of lymph nodes?
Level 1 and 2.
2, 3, and 4.
Yes, 1, 2.
Right,
1,
and
2,
2 and 3 on the opposite side also. Why? Because there is crossover of lymphatics in the tongue.
Lymphatics.
And there is a churning effect of lymphatics. Okay, so that is why a bilateral dissection is done for malignancies of tongue. Now, supposing it had come out to be adenocarcinoma, what are the other possibilities? Supposing you did a biopsy and it turned out to be adenocarcinoma. So you need to keep in mind minor salivary gland malignancies. Okay? Yes. There are, other than the tongue, there are minor salivary glands in the tongue also, which can undergo a malignant change. Okay? So what are the technical considerations in your mind when you manage this case?
Well, we can do PMMC graft or radial slab can be done.
Sorry?
To restore the after doing
one technical consideration is that you want an R0 resection, right?
Yes, ma'am.
Then yes. Another technical consideration is that you want good functional results. Okay. Functional result. Then yes, another technical consideration is that you want to avoid post-operative complications like a tongue fallback or aspiration. Right? You may need to maintain the airway if floor of the mouth is involved. Okay, then if the floor of the mouth is involved and the lesion is going far too posteriorly, you need to make your incision accordingly. Right? So what are the incisions by which you can access the posterior aspect of the tongue also on the lateral side? So you can do a mandibular split Or you can do a what? You design lip split can be done, mandibular split can be done. So these incisions, crease line incisions, you need to know of. Okay? Yeah.
Yes.
So how do you reconstruct the tongue?
With radial graft and the PMMC.
So you may use free flaps to reconstruct, or pedicle flaps also.
Yes.
Yeah. So the basic thing is you need to recreate the lining,
Yes.
support and cover wherever you think of reconstructing.
Reconstruction.
Hmm?
Yes.
Yeah. So if mandible is involved, what kind of mandibular resections are you aware of?
Selective mandibulectomy.
You need to know about segmental mandibulectomy, then
segmental mandibulectomy, and if the alveoli alone is involved, we can
marginal
do
mandibulectomy,
marginal mandibulectomy.
and segmental mandibulectomy and hemimandibulectomy, right?
Hemimandibulectomy. Yes.
So when will you do segmental and when will you do marginal?
If the alveoli is involved, we can do segmental marginal mandibulectomy. If the mandible
alveoli, so one table is involved, you consider marginal mandibulectomy, right?
Marginal. Yes.
In a knee dentulous patient or geriatric age group, you cannot do a marginal mandibulectomy. What are the ways of reconstructing the mandible?
Bone flap from
composite flaps, right? Or by plating. Now, what is the disadvantage of taking a composite flap in primary reconstruction? You need to subject them to radiotherapy, so it can cause osteoradionecrosis. Okay? What do you understand by the term concomitant chemoradiation?
The chemotherapy and radiation given at the same time.
Sorry?
The chemotherapy and the radiation given at the
they're given
same
together.
Time.
Yeah.
Yes, given together.
So the role is in either very early malignancies where you want to maintain the functionality, right? Or in locally advanced also where you want to downstage the tumor faster. Surgery is the mainstay of treatment in oral cavity malignancies.
Yes.
Yes, you need to know about neck dissections and the types. You need to know the boundaries of all the levels of lymph nodes. Okay, and the complications. Can you do a bilateral, what are the types of modifications that you know of in neck dissection? What is MRND 1, 2, 3?
Modified radical neck dissection usually.
What are the three types? Nowadays, what you talk about is selective block dissection without giving it these names. Otherwise, radical, if everything is involved, MRND, functional neck dissection, supraomohyoid with the terms used earlier. Now you talk about the levels which are involved and you need to know the boundary of all the levels. And what are the structures which can get injured? Yeah, can you take out internal jugular vein on both the sides?
No.
You should not, right? Because it can lead to cerebral edema. So bilateral, you cannot take that out. What are the other complications that you're aware of? Can you name some nerve injuries that can happen in neck dissections?
Spinal accessory nerve.
Sorry?
Spinal accessory nerve injury.
Yes, spinal accessory. What else? Hypoglossal ansa cervicalis, right?
Yes. And vagus, no.
Yes.
Vagal injury.
Very rarely, but yes. Then phrenic nerve can get injured in level 5 area.
Yes.
And then on the left side, cisterna chyli can get injured, which can lead to massive lymphoria, can even result in mortality because of hypoproteinemia. Dr. Sahai?
Yeah,
Yes.
I think anyone would like to ask anything before we wind up?
Yeah.
Okay, Dr. Ratna, please assess his performance.
Yeah. So liberal in the sense I would still pass him. He's made an effort to present. I'm giving borderline pass. And again, you need to improve on your confidence levels when you speak. Use correct terminology and do read about, think in terms of knowing the anatomy and what is the pathophysiology which is leading to disease, based on which you will take the history. And each symptom and sign you should be able to explain as to why it has happened. And then operative procedure. For operative, it is very important in oral cavity malignancies to know about the different incisions that you can make for accessing various sites in the oral cavity, right? So, and the types of neck dissections, of course, that we've talked about. Keep presenting. You've done a good job presenting it.
Yeah, Dr. Sai,
I
do you
like
have
the
any?
font that you have used, but it is good to use Times Roman numeral when you are making a formal
Right, I was also
presentation.
going to say the same thing. Look, you should use the standard fonts, right? Times or Calibri or Calvary. Okay, so Dr. Sai, any doubts, any clarifications, anything you want to say about your presentation? Sai, are you there?
Yes, sir.
Hello.
Sir.
Yeah.
Hello, sir.
Anything?
Hi, sir. Sir, it's able to assess myself, sir. I definitely need to improve. I will improve in my future presentation. Thank you for the.
I think it's very brave of you to present to such
Keep presenting.
examiners.
And even in the exams, if you're asked a question, you're not able to answer that, please do not get depressed and stop answering. The next question will come. If you're not able to answer, say, I'm sorry, I don't know. The next one will come, okay? So if you know the subject, sometimes it happens that you may not be able to answer one or two questions sequentially, but don't get worried. Keep your head in place and be ready to answer the next question. Okay? No need to worry. You are more well-read than any one of us because you would have gone prepared, no? Yeah. Have faith in yourself. If you have faith in yourself, then only others would have faith in your presentation. If you will think you don't know anything, why should I think you know anything? No? You should know that you have read and that you know your stuff. Yeah, you've done a good job.
Yeah, for me, Sai, I would give you an 8 out of 10 because the examination won't go so far and in so much of depth in the exam, but still, well, go and read about it. Anyone else would like to comment? Otherwise, we'll call this session a close. Okay, thank you so much, Dr. Ratna. Thank you so much, Sai.
Thank you, Dr. Sai.
Hope to
Good
see you
night,
next week,
everybody.
next Friday. Good night, everyone.
Thank you.